Hello, everyone. My name is Ola Mipo, and this is my psychopharmacology case presentation. I'll be talking about bupropion. Bupropion is a norepinephrine and dopamine reuptake inhibitor. It doesn't have any effect on serotonin, histamine, acetylcholine receptors, so it has a very unique effect profile. It's the only NDRI on the market, and it increases the dopamine neurotransmitter in the nucleus accumbens, as well as the prefrontal cortex. It is distributed under the trade names Wellbutrin and Zyban. Bupropion is used in the treatment of major depressive disorder, but it is not considered first-line treatment. For this use, it is marketed under the trade name Wellbutrin. Under the trade name Zyban, bupropion is used to treat smoking cessation. It reduces cravings and withdrawal symptoms related to smoking. Off-label, bupropion is used to treat attention deficit hyperactivity disorder, seasonal affective disorder, and as a supplemental therapy to weight loss treatment. Some common side effects of bupropion include dry mouth, nausea, diarrhea, weight loss, palpitations, agitation, and constipation. Some more serious side effects include suicide, homicidal ideation, mania, glaucoma, and seizures. Generalized seizures have been reported in patients taking bupropion at a rate of approximately 0.4%. As a result, bupropion is contraindicated in patients at risk for with a history of seizure disorder. If the total daily dose of bupropion is less than 450 milligrams per day, this reduces the risk of seizures. Bupropion comes in immediate release and extended release formulations. The immediate release forms come in 75 milligrams and 100 milligram tablets, while the extended release forms are available in 100, 150, 200, and 300 milligram tablets. The immediate release tablets are taken twice a day, while the extended release formulations are taken once daily. The total daily dose is typically 200 to 225 milligrams a day, and it can be increased up to 300 to 400 milligrams per day after a span of 3 weeks. So now to our first case study. Samuel is a 32-year-old African-American male who presents to the clinic for a new patient evaluation. He reports that his sister, who's a nursing student, advised him to seek care as she was getting worried about him. He reports a loss of interest or even pleasure in playing soccer with his friends, which he does about twice a week. Also reports low energy, difficulty sleeping, and generally feeling down. He states that he would love to sleep, but this has been quite difficult lately. He states that he feels worthless and of no use, but denies thoughts of harming himself or others. Reports difficulty concentrating at work, also denies auditory, visual, and tactile hallucinations, as well as OCD symptoms. He denies being on any new medication and reports a history of depression. He states that he has been on sertraline and Effexor in the past, but they didn't work for him. States that of recent, he was on Effexor, but he got frustrated because it wasn't working, and so he stopped taking it about 3 months ago. Has a past medical history of allergic rhinitis and takes medication for this daily. So his behavioral mental health history, he had his first psychiatric evaluation at age 25 and was diagnosed with depression. He was started on Zoloft, which at first was working, but at some point stopped working. Doesn't have any history of substance use, no prior hospitalization, and no outpatient treatment. He is on Claritin 10 milligrams daily, and up until 3 months ago was supposed to be taking Effexor daily as well. Has a past medical history of allergic rhinitis, depression, and tobacco use, and had wisdom tooth extraction surgery, no history of allergies. He was born and raised in Glen Burnie and reports that he was raised in a monogamous family. He has 2 brothers and 1 sister, and both parents died in a car accident when he was very young, so his mother's sister raised him and his siblings. Reports that he thinks his dad was on medication for depression when he was alive, but states that it was never confirmed and no one knew for sure. Reports that his mom had high blood pressure before she passed and she was managed on medication. He denies any family addiction history and any developmental problems or delays. He reports a history of smoking 1.5 packs a day for 4 years, and states that he's been trying to quit and has tried nicotine, lozenges, gums, and patches. He currently lives with his two brothers and works as a business analyst in DC, has a bachelor's degree, and is single. So his review of system was pretty remarkable. Everything was negative, didn't have any complaints. Mental status exam as well was fine. He was alert oriented ×3, fairly groomed, dressed according to weather, speech was fine. Thought process was spontaneous, no memory deficits. Mental status was overall good. Physical exam, he didn't look like he was in any apparent distress. Cardiac, respiratory exams were all good. His mood was stable, had a bright affect, and fluent speech. So I did a PHQ-9 questionnaire on him, and he scored 16 out of 27, and so was diagnosed with major depressive disorder, moderate kind, and has a history of allergic rhinitis. He was the source of the history, and he was a reliable source. Assets, he has a good medical health insurance, and so whatever medication I put him on, he'll be able to afford it, combining that with his medical insurance. And for liability, he lives with his two brothers, so really he doesn't have any privacy when he's home. So for treatment plan, I decided to start this patient on bupropion, 150 milligrams daily. So he's to start bupropion and for depression, and this may also help with smoking cessation. He's also to attend therapy and come back to be reassessed in 2 weeks. I discussed possible side effects with the patient, such as dry mouth, nausea, headache, and so on, and advised him to seek medical care if he experiences any of these and if it starts to get worse. And he verbalized understanding. As far as cultural diversity, bupropion has been proven to be an effective treatment for depression and smoking cessation in African American males. So now on to the second case study. It's the exact same patient profile, just with a couple additions to it. So same history information, but this patient has a past medical history of allergic rhinitis and seizure disorder. Reports that seizure disorder is being controlled with medication, and he has not had a seizure in about 2 years. Patient is on levetiracetam, 500 milligrams twice a day, and has a past medical history of a motor vehicle accident in 2015. This patient doesn't have any history of substance use or outpatient treatment, and has that history of the car accident that put him in the hospital. Same history, lives with brothers, works as an analyst, and is single. Doesn't have any developmental delays. Review of system, the same, nothing to report. Mental status exam as well looked good. Physical exam as well looked good. Cardiac, respiratory, all those measures looked good. So in conclusion, bupropion is utilized in the treatment of major depressive disorder, but it is not considered the first-line treatment. Hence, it is utilized in patients after other first-line agents have been tried and have failed for the patient. It is also used to treat smoking cessation, as it reduces cravings and withdrawal symptoms related to smoking. Bupropion is contraindicated in patients at risk for or with the history of seizure disorder. As a result, bupropion will be a great medication for the patient in case study 1 who had tried Effexor and sertraline but didn't like it, and also has a history of smoking. So this will be a very good medication to put the patient on. However, with the history of seizure disorder, bupropion becomes contraindicated in the patient in case study 2 with that history of seizures. For a patient who has been on other antidepressants before and they didn't work, I anticipate that the patient in case study 1 may be skeptical and hesitant to try another medication. However, I'm sure that he desires to feel better, and that's why he sought treatment today. With this in mind, I will empathize with the patient for having tried different medications for depression and how frustrated he must feel at this point. I will then explain to the patient in layman's terms the reasons why I have ruled in bupropion in this case, or ruled out if it was the patient in case study 2 who wasn't eligible for bupropion. So I will discuss this with the patient and explain based on his history and current health conditions. After this, I will pause and ask the patient for any questions he may have and try to answer them to the best of my ability thoroughly. This will help the patient be more open about trying a new medication. So this was a very informative case to prepare, and I really learned a lot. 3 things that I learned from this case study. One is that a patient's past medical history and current medications play a huge role on what kind of psychotropic medication he or she should be started on. A thorough history of present illness can aid in prescribing the right psychotropic medication for a patient, as some psychotropic medications can help medical problems inadvertently. And lastly, bupropion is a good antidepressant medication for a person who has a history of depression and ADHD and is also trying to quit smoking. Thank you for listening and have a good one.